All right, welcome back, everybody. My name is Lisa Wilde. I'm at the University of Utah and the Salt Lake City Veterans Affairs Healthcare System. It is my great honor today to introduce our next speaker, Dr. Cheryl Wellington. Dr. Wellington is a professor and vice chair of research for the Department of Pathology and Laboratory Medicine at the Javad Moaffagian
Moaffagian, yeah.
Observational Center for Brain Health, the University of British Columbia. Dr. Wellington's major research interests include Alzheimer's disease and traumatic brain injury. Dr. Wellington founded the UBC Core Facility for Neurology Biomarker Innovation, which focuses on development and validation of blood tests for a wide variety of neurologic conditions. Dr. Wellington holds multiple leadership and executive positions in the dementia and neurotrauma communities, including the Canadian Consortium for Neurodegeneration and Aging, Cure Alzheimer's Fund, the Canadian Traumatic Brain Injury Research Consortium, and the Canadian Concussion Network, the International Initiative on Traumatic Brain Injury Research, and is a member of the Global Biomarker Standardization Consortium. Her talk today is entitled ASCEND, stands for Advocates, Academics, Survivors, and Clinicians to End Intimate Partner Violence Initiative, a prospective observational case control study protocol to identify plasma biomarkers of intimate partner violence caused brain injury. All right, Cheryl.
Thanks so much, Elisabeth, for a very, very kind introduction. And thank you, Carrie, and all of the organizing committee for the opportunity to represent a very, very large team. And what I'll do today is describe some of our overall major programs that we're undertaking right now, with the focus really of building better diagnostic tools to document evidence of brain injury that's caused by intimate partner violence. So here you can see a very long list of contributors. The principal investigators of the study, excuse me, are listed in bold. And I hope I haven't missed anybody as within the trainees and staff members that are contributing to this major study. So let's see, I'm still having some trouble. There we go. Okay, so some disclosures for peer review, excuse me, grant funding, none of which conflict. And of course, I will be discussing some sensitive topics today. So again, just reflecting what we've heard today, feel free to leave the room at any time. And anybody can also contact me if you have any concerns or questions that you'd like to discuss further. So, of course, we're talking about intimate partner violence today, which has just an astonishing prevalence, with the majority of survivors very likely having experienced some form of brain injury. But there's a lot of questions about how do we actually provide evidence that the brain has been injured. This is incredible implications for the medical care as well as forensic and medical legal outcomes of what evidence can be gained to document that there has been this type of injury. One of the things that excuse me, I'm recovering from a cold, so I have this little bit of a reactive airway. So in addition to traumatic brain injury, which is a mechanical force that is experienced by the head, and we know from the Concussion Legacy Foundation that exposures in American football players and other professional athletes can lead to a neurodegenerative condition called traumatic encephalopathy that shares some pathological overlap with Alzheimer's disease and related dementias. So the long-term consequences of the mechanical trauma, the impact, head impacts remain poorly understood in the context of intimate partner violence. But what makes IPV different is that it also very often includes non-fatal strangulation that we've heard about today, and that also, because it restricts blood flow to the brain, also has a mechanism by which the brain can be damaged. And we don't know if the two are simply additive or if a person experiences both head impact and non-fatal strangulation, whether there could be a more severe type of injury, and how to distinguish these two etiologies. Advances in the last decade or so have made it possible now to develop blood tests that can measure a lot of things that are happening in the brain, and these are called biomarkers. And so I have here a little cartoon of a brain cell, a neuron, which can release a number of different proteins under normal circumstances, as well as when the brain is injured. We can measure these proteins in cerebral spinal fluid if we take a lumbar a lumbar puncture, but we can also now measure them in blood samples. And this has really revolutionized how the field of neurology is progressing to improved diagnostic tests. For example, there's a blood test now that measures a protein called p-tau217 that can be a very good diagnostic of Alzheimer's disease. One of our study members, Dr. Sandy Schultz, published a study that was led out of Melbourne in Australia, showing that the blood levels of a protein called neurofilament light were higher in survivors of intimate partner violence that experienced head trauma when reporting to the emergency room. And these levels were higher even in compared to mild traumatic brain injury or concussion cases that came to the emergency department, and were also higher than trauma control. So people with orthopedic injuries, that includes, in an injury to, say, an arm or a leg, as well as healthy controls. So it does seem to be true that survivors of intimate partner violence may have a measurable difference, an elevation of these of at least neurofilament light, potentially other biomarkers. Paul Van Donkler, who needs no introduction to this field, who will give the keynote address tomorrow, will tell you a little bit more about what we're doing in terms of the results of the study. But he has played instrumental roles in understanding the neurovascular consequences of intimate partner violence, showing that survivors typically score lower on measures of memory, whether it's working memory or episodic memory. And this, we don't know if it's the strangulation that's really driving this, the impact, like concussion-like impact, or the combination of both. And he's also shown that the blood levels of another marker that reports on brain inflammation seem to be higher in survivors with a higher exposure to intimate partner violence, which are shown in the warm colors on this heat map. And this is related to changes in how the blood flow patterns are moving in the brain. So there's a number of different approaches that we are taking to really try to understand, can we measure and document physiological changes that happen in the brain after intimate partner violence, both at the acute setting as well as in months or years after. And so this really allowed our group to come together and apply for a grant from the U.S. Department of Defense that was funded. That really has two major objectives. And the first one is to use plasma biomarkers as novel tools to assist clinicians in improving the diagnosis of IPV-caused brain injury at the acute, subacute, and chronic stages. And of course, this is all done in a manner that is trauma-informed and very sensitive to the needs of this vulnerable population. So right from the get-go, we have designed this study to be really focused on IPV and not just cut and paste what has been done or what might be done in a typical, say, sport-related concussion study. We're also very interested in informing the field of Alzheimer's disease and related dementias. I know that from an informal survey of talking to my colleagues in this space, nobody that I have spoken to inquires about a history of intimate partner violence in older people that come into a memory clinic with a potential query about their dementia risk. And this is true even though we know that women have 2 to 3 times a higher rate of diagnosis of dementia than men. And although there's a lot of work understanding, sex-based differences in dementia risk, very few people other than us are really trying to understand, is there an attributable risk due to exposure to IPV and IPV-related brain injury? And what does that exposure threshold look like? So this is really the overarching purpose of the ASCEND-IPV Consortium and our initiatives. And so we now have our funding from the DoD that started us off. I'll talk about our second grant that builds on this. And then we also have funding from Brain Canada and the Canadian Institutes of Health Research to build on this overarching objective to get better diagnostic tools and have some information about the long-term consequences of IPV-BI. So I'm going to spend some time really talking about our study design, which was published a few months ago in BMG Open as a protocol paper. To really try to showcase to the community here the rigor and what we're really trying to achieve in this study. So it is a prospective, observational, case control, multi-site Canadian study where we are recruiting survivors of an IPV event, and we're classifying them into 4 groups. Those survivors with a suspected BI due to strangulation, those with a suspected brain injury due to head impact, those with suspected brain injury due to the combination of strangulation and impact, and those without a suspected brain injury. So these could be other types of intimate partner violence that do not include the physical impacts to the head and neck. We have a target sample size of 500 that are enrolled at the acute and subacute stages. So this covers up to about a month after the incident. And we have a target enrollment of about 100 participants that have experienced IPVs months or years prior. Our primary outcome is deploying the Alamar platform. I'll tell you a little bit about what this is, to do a discovery analysis of over 130 blood-based biomarkers. In addition to the blood biomarker study, Karen Mason, who's the founder of SOAR, and again is a legend in this community. She has really been involved as our person with lived experience and is championing the development of the living practice guideline that will come out of our study. So we have 4 sites that are currently rolling within the province of British Columbia and Canada. So we are enrolling from the Embrace Clinic at Surrey Memorial Hospital, which is run by nurse practitioner Hannah Varto. Just an exceptional site that is renowned and unique in Canada for serving victims and survivors of any form of violence. And she has many, many years of history in working with IPV and is doing an exceptional job. We also have enrollment from emergency departments on Vancouver Island, including at the Nanaimo Regional Hospital, the Cowichan District Hospital, and the West Coast General Hospital. These were intentionally selected to be outside of major urban emergency departments to really capture what do we see in more rural and remote areas. And we also are enrolling, and our major site for the chronic enrollment is community organizations in Kelowna, as well as community organizations on Vancouver Island. And these are just some pictures of beautiful British Columbia. And I hope that someday we can showcase another major symposium from our sites. So the methodology is within the acute and subacute time periods. So basically, this is within the first 30 days after a violent incident. Participants will come in, be screened, and consented and enrolled. There is a very streamlined case report form that collects a lot of information and does not require participants to return for any sort of follow-up. And we get a blood draw, and that blood is processed and sent to my laboratory at UBC for analysis. For the, excuse me, for the chronic methodology, it's a very similar procedure where our participants are screened, consented, and enrolled into the study. We assess their history and experience of intimate partner violence, delve a little bit into the injury mechanism and the clinical information, and again, collect blood. And we are deploying mainly the Alamar platform to be able to measure blood-based biomarkers. Alamar is a brand new technology, and we are very happy to be the first in Canada to be unrolling this technology, where in about 30 minutes of total hands-on time, we can measure 131 actually, for the newest iteration of their central nervous system panel of protein biomarkers. And it is just a remarkable machine that we are running on also a lot of Alzheimer's and neurodegenerative studies as well. So we're really going to town on this. There's for the clinicians or lab medicine people among us, there's a lot of measures that are highly relevant to Alzheimer's disease, markers that are relevant to how the brain communicates, markers that are relevant to the function of the vascular system within the brain, other general markers of neurodegeneration, and other markers of the inflammatory process that happens after any injury to any body system. So together we have a very powerful panel to identify novel diagnostic tools to be able to document, is there a brain injury, and does that pattern look different between whether it's impact, strangulation, both, or none? You can see here that we're doing really well. Our enrollment is right on track. As expected, most of the participants enrolled to date are female and cisgendered, but we are definitely enrolling people that identify as men and other genders, and these will be analyzed as case series or case studies. The age demographics of our current roster of participants is shown here. So our study participants in blue, you can see they're a little bit younger than the average population in the Lower Mainland, and so we have a high population of retirees. And the ones that have, the survivors that have a plausible mechanism of brain injury also tend to be a little bit younger than those without a plausible mechanism of brain injury, so no impact or no strangulation. This is important for us to track because we know that the levels of many of these biomarkers just naturally vary by age. So this is a really important variable so that we can eventually be able to express biomarkers as an age-adjusted score and be very rigorous in our analysis there. This is just looking at the days past the most recent incident, and the most time frame that we have people enrolled is 6 to 10 days after the incident. This is also important for us to recognize because some markers will peak very early and then be back to normal within a few days, and others take a while to come up. So understanding the time frame at which blood is collected and measured is a really important aspect of this work as well. And again, here we're seeing that the participants that have a plausible mechanism of brain injury tend to come a little bit earlier to attention, like a mean of 8 days after the injury compared to those without a brain injury. So this is all sort of some of the data that we need to consider when we apply our statistical analytical plan to looking at what we're seeing in the blood. This is as expected. We have about 80% of our participants have a plausible mechanism of brain injury, roughly equally split between whether it's head impact, strangulation, or both. And then about 25% without a plausible mechanism of brain injury. So we're doing really well in being able to classify the participants into the different groups in this observational study. We're also collecting data on their history of intimate partner violence and how many times they have experienced head impact or strangulation. And you can see here, it's just very sobering for me to reflect on these data. And so we are so grateful for the participants to come into our study. So to date, we're very happy to say that we're right on track with where we are enrolling. So this is our enrollment so far. And Paul will be able to show some preliminary data when he gives his talk tomorrow. Karen is very much in charge of building the knowledge translation tools. So we will be developing the living clinical practice guideline for assessment of potential brain injury using blood-based biomarkers, building off of previous work that Karen and her team did to build the concussion awareness training tool for women support workers. And this is the QR code where you can access that tool if that will be of interest to you. There's also a public service announcement that the investigative group were involved in developing with Trevor Linden, a former professional hockey player, that has a very, very powerful public service announcement on IPV-BI. And so with the funding that we have now in place, will be the living clinical practice guideline for IPV-BI. We'll be able to provide a review and primary data on potential links between experience of IPV-BI and whether there are any concerns or potential elevated risk for Alzheimer's disease and related dementias, as well as vascular contributions to cognitive impairment and dementia. This is going to be very important for the Alzheimer's community, especially if they have women coming into their clinic with memory problems, to learn how to inquire about a potential history of IPV. And this is just not done at all yet. And so we want to be able to provide trauma-informed guidelines for geriatric neurology researchers and clinicians to be aware that that is very likely that they have seen survivors, in their clinic, even though if they don't realize that yet. And so we definitely are looking for a lot of people with lived experience, clinicians, and various other people with vested interest in these KT tools to help us build and test them. So please contact me if you're interested to be involved. With the practice guideline, the approach will be to use the practice guideline evaluation and adaptation cycle to guide development. And Karen has formed a interdisciplinary guideline evaluation group that includes survivors, advocates, clinicians, and researchers to adapt and modify previous guidelines through consensus. So what we will be adding here are really, once we fully analyze our blood-based biomarker data, do we have new tools that can help document evidence of acute or chronic brain injury? What are the implications of that to care? Can that be used to provide better care, access to care? Are there any harms that could be coming from that? What about its utility within the medical, legal, and forensic systems as well? So we view this as something that we would like to update annually as we go through this project, as well as other planned projects that we're developing now within the group. Since we published our paper, we now have a second U.S. Department of Defense award that helps us build even more onto this program. So this new program, this new grant, supports 3 additional arms of this overall large prospective study. The first aim is to get a lot more mechanistic, where we're now going to be building a novel murine model of non-fatal strangulation, so that it can be used in combination with mouse models of traumatic brain injury, so that we can really understand the mechanisms of exactly what happens to the brain tissue after impact, after strangulation, and in a combination type of injury. And so we're going to be doing this in just, normal, what are called wild type mice, and then also in an advanced model of Alzheimer's disease, where mice are engineered to develop amyloid plaques and neurofibrillary tangles the way they do in human Alzheimer's disease. We also, excuse me, will be able to assess much more detail about psychological health. And I'll describe a little bit more about what we're doing in that area, looking at to see, what does the experience or how does a brain injury impact recovery and psychological health after it's experienced. And then we have a really interesting new area where we're going to be trying out this sort of a new method of using transcranial Doppler, which is a way that blood flow patterns in the brain can be examined, and taking it right to the Embrace clinic, where participants are coming right for their initial medical assessment. And this is potentially another real world, real time way in which we can maybe assess, are there changes in the blood flow patterns in the brain that can maybe explain some of the psychological and cognitive sequelae of brain injury? But even more so, can we then detect, potentially life-threatening consequences of strangulation that include carotid dissection, which is a risk for stroke? So this is a non-invasive way, and I'll describe some of the innovations that we're using here. So for the mouse model work, I previously, 10 years ago, worked with Dr. Peter Krypton, who's a mechanical engineer, and we built a mouse model of concussion that is now widely used worldwide. And we now want to go back and use, engineering principles to really develop a reproducible model of non-fatal strangulation, building on a prototype that was published by Sandy Schultz about a year or so ago. And also building on work that we've done with Mark Sombrowski in using spatial transcriptomics to really understand, the molecular changes that are happening in brain tissue after brain injury. So we published with Mark a paper that describes the first map of billions of gene expression changes that occur after traumatic brain injury in a mouse. And we'll be able to do the same type of thing once we get the strangulation model up and running. So to give you some ideas of how we're doing this, we have 3 prototypes of 5 that are shown here that we will be testing very soon. One simply kind of is a vertical compressor to kind of push the neck down on a support of a mouse. The other is going to come in from the side to try to maybe get more targeting of the jugular veins and the carotid arteries. And then we have a rotary drive that constricts just throughout the entire animal's neck. We'll be using Doppler to assess the degree to which we are occluding blood flowing into the brain, and then carrying this on into more work. With the second aim, it's going to be Paul and Noah Silverberg, just an incredibly eminent neuropsychologist in the field of traumatic brain injury, to really assess psychological health. We really want to determine if there is a difference, how big of a difference does the brain injury take? And again, do we see distinctions between people that have head impact alone, strangulation alone, or both? And then determine how depression and PTSD contribute to the differences observed, and then relate the psychological scales to the blood biomarker patterns that we will be measuring. So we'll be doing a composite score from a battery of 5 neurological tests, as well as the CREOS platform adjusted into an overall test battery mean. And we're going to be doing this with instruments as well as a semi-structured interview. So we're so grateful to be able to bring that on. With the Doppler, this is really, almost a science fiction. And it's going to be done in combination with Ryan Hoyland, who's an early career investigator and one of the leading Canadian experts in cerebrovascular physiology. So he's been using this system in intensive care unit where there's a lot of stroke or traumatic brain injury assessments of blood flow in the brain. And Hannah is our nurse practitioner at the Embrace Clinic. What makes this system different, the way that transcranial Doppler works is basically it shoots some ultrasound in through the temporal windows. And it's been pretty tricky until this device got originated, because it takes some finesse to be able to really get into the, identify how to align the Doppler to the patient's head. This device here uses artificial intelligence automated honing on the temporal windows. And it really makes it, essentially plug and play. So we'll be able then to assess the feasibility of using this kind of system in a real world clinic when patients are there to assist in the diagnosis if there is any, changes to blood flow. And this is some preliminary data showing that, well, we might be seeing something here, especially, with participants that have had experience of strangulation. They have, you can see here, deficits in their blood flow patterns, as well as when we measure neurovascular coupling, which is the concept that areas of the brain that are active pull blood flow to those areas of activity. You can see here that people with high exposure to intimate partner violence have a less robust response, especially in the posterior cerebral artery, than participants with low exposure. So we think this might be a really excellent clinical tool to, again, provide real-time assessment and documentation of a physiological injury to the brain. So I'm really speaking on behalf of such a large team. And so we're really doing our best to create studies that can understand how brain injury affect cognitive decline and neuropathology, taking into account the incredible heterogeneity of IPV survivors in terms of age, mechanism, exposure, and many, many other variables. We're trying to couple, make this a translational program because it's very hard to study all of these variables simply in the clinical population. And here's where we're using model systems like the mouse models I talked about to supplement what we're doing clinically and be able to tease apart and have very defined injuries in different groups that we can study. And then really, bring these results not only to the emergency acute care medical personnel that are caring for survivors, but also bring it forward to other clinician groups, such as geriatric clinicians, in really starting to consider or thinking that or learning that they should be considering intimate partner violence in their assessment of dementia, and also to other sectors that could be using evidence of physiological injury for both legal and forensic purposes. So with that, I will again showcase, some of the principal investigators on this team, and just express my gratitude to everybody on the team and all of our trainees. It is a huge effort, and the dedication of everybody on the team is just absolutely incredible. I also really want to give a shout out to the survivors that we've heard the stories today. I'm so humbled being just even part of a team that's working in this area. I'm not a clinician myself, and so when I first really started hearing, Paul and Karen talk about IPV and IPV-BI. It was a real honor to think, well, maybe somebody like me that has expertise in laboratory medicine might be able to make a contribution to this field of research as well. So we've really been grateful and happy that we have pulled together this really interdisciplinary team. We now have these 2 major grants from the US DoD, and we're off to the races. So Paul will share a little bit more about the results of what we're seeing, and I hope to be able to come back, Carrie, in a couple of years to describe a little bit more about what we're doing in this overall project. So thank you so much for your attention today.
Cheryl, that was a fantastic talk. Thank you so much. This is such important work that your team is doing. I did want to draw your attention to a couple of questions that we got in the chat. The first one is on the Alamar biomarker testing. How far out can it be used for TBI survivors from the trauma incident? Can it be used years out?
Yes, it can. The LMR platform is one of the leading platforms that is being researched in neurodegenerative conditions, so Alzheimer's, vascular dementia, et cetera, et cetera. So we're really understanding kind of what the older brain looks like normally, as well as when neurodegeneration is occurring. And this will be the first time we'll be able to really use it in, say, chronic or older survivors of IPV as well.
Fantastic. Another question was, how have these efforts been impacted by funding cuts this year?
We are, well, so far, the both DoD grants seem to be safe. I was on 2 NIH grants that got pulled, but so far the funding seems to be solid. So we're just hoping that continues. And if that changes in any way, shape, or form, that we will be able to find Canadian sources to backstop what we're doing.
Fantastic. All right, another question is, how do you see these biomarkers being used as forensic evidence in both the criminal and civil court system as positive findings of non-fatal strangulation and the relationship of charges and convictions?
Well, I'll just start by saying, I'm not, I don't have legal or forensic expertise. That's not my area. And so, but I do think that similar to how, X-rays or MRIs can document other types of injury, these methods that we're using here, whether it's a blood test, whether it is the transcranial Doppler, will provide evidence of a physiological change from what is considered to be kind of the normal or healthy or uninjured situation. And so that launches a whole bunch of research that we need to do, is to, like, how many people recover completely, how many people are still, left with sequelae. Can we tie those things together? And I think that is the kind of evidence that the legal system is really lacking. We don't have good ways to document physiological injury. We've heard over and over and over again today that many survivors, I mean, you don't really remember, exactly what happened, and this can kind of fill that gap to say, yeah, this is what has happened. We are really aware of the potential for some of these data maybe to be weaponized, and so we're very aware that we need a lot of research around that and educating the legal system, that this is not in any way, shape, or form a reason to, to be hard on people that have survived. For example, I know that there's concerns, if people have children, would this impact custody battles? But I would say that if somebody has a regular old car accident or they fall off a ladder and get a TBI and we can measure that by biomarkers, we have no problem, keeping families together there. So just the fact that there's a physiological change is not reason to, to be negative in any other way. So we want to be able to show how IPV-BI may be similar or different from other kinds of brain injuries, and really go from there. So part of our work is to be, and we do have people with legal expertise within the team to really start exploring how do we best use these data to educate the other sectors that the ways to document a brain injury are coming.
Fantastic. And then there was one follow-up question about how to get an LMR test. How would you get that kind of referral?
So we are happy to collaborate with anybody that could be drawing blood in research studies. None of these tests are approved for clinical use yet. But certainly for Alzheimer's diagnosis, it is coming. The LMR is not quite there yet. There are other tests on other platforms that we have running here at UBC that for anything that is approved, we could then do the test. But right now it is within the research space. But there's so much movement. The field of neurology is really moving toward being heavily invested in lab medicine. And so the tests are coming, they are being rolled out. And as soon as we can offer them, clinically, we will be able to do that. In the meantime, if there's any of the researchers or people that want to participate in research, please do contact me. There are ways even just to do a little fingerprint, collect a dried blood spot that can be mailed to my lab. And so there are many ways to expand.
Fantastic. All right, and I just had a question for you. I know that this is kind of the aim of your second DoD project, but what do we know so far about the differences in specificity for biomarkers for non-fatal strangulation versus head impact?
We don't know anything.
We don't know.
It's a totally blank slate, and that's one of the major impetus that we want to be able to bring forward and really understand. Do we see different patterns? Say if there's a head impact and it's, it is say stretching axons. If that gives a different type of injury signature than if you have poor blood flow and that's starving a neuron, say, of oxygen. We do not know at this point.
Fantastic. And I just have one last question in our last few minutes here. So you mentioned that it's not quite, the blood testing is not quite available in clinical practice yet. What would you see as the pathway toward getting that into widespread use and the obstacles that exist to doing that?
High quality evidence is always the way to get something clinically approved. There is a point of care test that is approved by FDA in the US, Europe, as well as in Canada, that measures two markers that is approved to rule out the need for a head CT scan in adults who have experienced a traumatic brain injury. So it's very closely, that is an approved test. There's been very little uptake of this, though, clinically in hospitals, in the US as well as in Canada. And so, maybe IPV might be a really good way to kind of bolster uptake of this test. It's going to be needing to be performed, quite early after IPV, because both markers that it measures will come up and down really quite quickly. And so there's a lot of room to develop, maybe add, what are the markers that are best at, 2 or 3 days after versus a month after versus 5 years after. So our research program will enable us to fill in some of these major gaps and work toward creating tests that can that have the rigor in both the the way the test performs, as well as understanding how to use the test and how to interpret that for IPV-BI.
Wonderful. Well, again, thank you very much for your talk, and we're so excited to see what comes out of these fantastic projects.
Thank you so much for the opportunity.